Hi, everyone. We're a couple minutes past 3. Just wanted to give a few extra minutes here for to give people a chance to join. But I would like to go ahead and get us started. My name is Sandeep Patel. I am the Associate Chief Medical Officer for Eventus WholeHealth. I've worked in the post-acute long-term care space for the better part of going on, I would say, about 16 years now. And just like many of you, have seen the many changes that have evolved in the industry at large over that period of time, have endured those changes, helped our teams lead through those changes, and come out on the other side doing great, whether you're facilities, patients, or whatnot. The purpose of this call was really to come together around the latest surveyor guidance and the revisions to those guidance statements to help us better understand not only what facilities are up against, but moreover, really how organizations like ours, i.e. Eventus, and your respective organizations can work together to help lead through those changes through the collaborative partnership that we currently have. And so I recognize that your time is valuable, especially on a Friday afternoon, and therefore, from the team here at Eventus, we want to thank you for spending a little bit of that Friday afternoon with us here today. And my hope is you can walk away from this with some insights some actionable insights that you could take back to your facilities and to your respective teams, all in an effort to ensure that we are able to execute on many of these revisions and enhancements made to the LTC surveyor guidance process through CMS. And with that, it's as if we did not have enough to worry about in this industry. It goes to say that this space, while filled with its own fair share of challenges, at the same time, it keeps us on our toes. There's events happening all the time, whether we talk regulation, whether we talk concerns and issues that we address at our facilities. But it's despite the many things that are thrown our way, I view those challenges as rather opportunities to move the needle on not only the level of service that we all offer collectively to the patients, but really working together to make a dent in healthcare at large. And I think these changes in the survey guidance come at a very opportune time. This industry is clamoring for transparency. It's clamoring for more leadership, for more involvement, and from our vantage point, recognizing the fact that medical directors are going to have to evolve, if not already, definitely as these changes come to fruition next month. And I cite this article that you see here because there is a national movement to really dive deeper into what are medical directors really doing at facilities, what is the value add that they have for facilities, and quite honestly, do they have the ability to maintain the presence and knowledge base to help better serve you all, and at the end of it all, making sure that the patients are best served in this space. So I do think that the survey guidance statements are coming at an inflection point in the industry, and our hope is that our continued partnership together helps navigate through those inflection points and comes out on the other end successfully for all stakeholders. So by the end of this discussion, a few objectives. Number one, just want to define why we're all here today. Give a detailed overview of the updates that will require our involvement as Eventus medical directors and clinicians. For those of you that are joining us from facilities, once again, thank you. And I know we have administrators on the call, DONs on the call, perhaps MDS directors, some regional leadership of owner-operator chains and whatnot. And I know that a lot of this information is not new to you all, but I really wanted to take this in a way that we look at it from the dimension of what the facility is up against, what the patient needs are, but then also put it into a framework by which organizations such as ours can help you all, help lead through a lot of these changes in tandem with all of you at your facility. And then my hope is we can also offer insights as to what our Eventus medical directors and clinicians can do to help lead our partnering facilities through these changes. So with that, there are a mixed bag of feelings and emotions out there. Some saying, and even medical groups saying, this is not my problem, it's the facility's problem, compliance is their issue. And some facilities actually taking somewhat of a, shall I say, a lighter stance on these updates and not really too worried about remaining in compliance because they think it will automatically happen. I will say this. Compliance is very expensive in multiple ways. We're not just talking financial or penalties or FTAGs, but we're also talking the possibility of jeopardizing patient outcome, which at the end of the day, we're all here to optimize. So I look at these survey guidance statements as, yes, more amped up wording around the regulation that's been in place for some time, but at the same time, I think their heart is in the right place. I think it really is in an effort to truly reflect on what we've been doing for patients all this time and truly ask ourselves, is what we are doing and how we are doing it as an industry really where it needs to be given the patient of today? So compliance with these new updates is more paramount than ever, in my opinion. And with that, we're a team. At the end of the day, although we may have contracts with facilities, we still think of ourselves as an intimate part of the team on the inside. Every building has its own culture of leadership. We want to be a part of that. And navigating through these changes is going to take that dynamic effort more than ever through our partnership, through patience. And I say patience because there's going to be a lot of learning that happens and unfolds over the next few months after April 27th. That learning and that constant approach to process improvement as we learn more about how these statutes are going to be emphasized and surveyed and tagged, that we create processes and systems by which we minimize those prospectively from those points. So it's going to be a learning effort and require a lot of patience on all of our end to do so. I will also stress the teamwork. The interdisciplinary team has never been more important, I feel, than what this latest set of updates to the survey guidance brings to the table. And what I would like to do right now is hand the podium over to Jamie Smith, who is on the call today. Jamie, would you mind introducing yourself? And I would really love to hear, and I'm sure everyone would love to hear your perspective on going beyond just what we might feel is the usual leadership team in a facility, medical director, administrators, DONs, MDS, but really involving all members from top to bottom on the end goal of trying to maintain compliance with these new survey updates. So Jamie, could you help shed some light?
Yes. Hi, everyone. I'm Jamie Smith. I'm a nurse practitioner. I'm an educator here at Eventus WholeHealth. So happy to have you guys join the call. I'm sure we have nurses, administrators, and we believe in partnering, working together as a team towards the same goals. Right now, times are chaotic. We haven't quite had the surveys yet because we're waiting to see how things go over the next 4 to 6 months after CMS mandates these rules that are coming up. But we're going to learn together, support one another, learn and figure this all out as a team. Part of this will involve nursing education. It's a key part of learning together. We're excited to eventually offer nursing CEs to support professional growth, and we would like to have give everyone at the table, a seat at the table. It's not just for administrators and nurses, but also involving everyone, the frontline care force. Let your CNAs, let those who spend the most time with the patients be aware of what's coming down the pipeline with the CMS updates, because it takes a village and we can't work in silos. It takes a true team effort.
Thank you, Jamie, for chiming in there. Much appreciated.
You're welcome.
All right, so before diving in, first things first. One thing to make clear that we probably all know, these are not necessarily new regulations, but rather these are state surveyor guidance updates. So think of regulation that was already there and add maybe 10 exclamation points to it and put in bold. I think that's what they're really trying to bring to the table here in terms of these latest changes. If we look at the regulations themselves have been there for some time, but there are elements of those regulations that need to be emphasized in a much more nuanced way, and that's exactly what they've done. The last change to regulations were back in 2016, and as we knew, there was 2016 changes were phased in over a few years between 2017 and 19. These current updates are set to be enforced on April 28th. What was in February got bumped to March, now got bumped to April. We can look at that as a plus or minus, who knows, but hey, this gives us ample time to practice this. So let's dive in, let's start the work, so when the train is here, we're ready to board and not get smacked by it. And of course, here on the call today, I'm sure you're all here to see how Eventus can work to ensure that the very people that are helping to serve your building from the Eventus side, whether we talk primary care clinicians, attending physicians, primary care advanced practice providers, mental health providers, both psychotherapy and psychiatric medication management, as well as your medical directors, that they have a good working knowledge of regulations. Part of what we will learn going through this is and part of that article that I cited in the very beginning, there are education gaps as well, even on the medical director side. It's very difficult that if you haven't been in this space to learn everything surrounding the 800 plus pages of CMS regulation in long-term care. So we are actually striving to ensure that internally, it's not just the medical directors that get this sort of education. Every stakeholder that has some dimension of patient care receives education, especially surrounding any updates in the regulatory landscape. So please rest assured that our teams will be ready when this time comes upon us. Now, a few of the ones that we'll discuss today, of course, this doesn't represent every single change, but it represents the ones where I feel that both Eventus and our facility partners can work together on ensuring not only just compliance once again, but best practices in the space, and working together to make sure we create policies and procedures and protocols that make sense, yet do not take away from efficiency at the ground level in order to execute them all in the effort to help avoid survey risk. And a couple of these might not be, actually one of them in particular, might not be directly obvious. Well, what the heck does medical directors and attendings and whatnot have to do with transfers and discharges? I've had that comment made by other other practice groups, but it's surprising when you dive into the language how much we actually can offer and how much we actually have to work together for it. So with that said, I'm just going to go ahead and dive in, segueing into transfers and discharges. So the key updates surrounding the language and the transfers and discharges is that there are certain terms that have been eliminated. Whether we talk resident-initiated discharge or facility-initiated discharge, the terminology has been removed. Basically, a transfer or a discharge is a transfer or a discharge regardless of who initiates it. But the bottom line is everyone has a stake on making sure that if a patient is transferred or discharged from the facility, that wherever they are going, we have an obligation to be sure that they're going to a level of care that will meet their needs in one way, shape, or form. Of course, there are exceptions to that, but the focus here will really be on the language of the transfer and discharge update and where everyone kind of fits into that piece of the puzzle. Inappropriate discharges or transfers may generally be cited as severity level of harm, level 3, or immediate jeopardy, level 4. So just know that these are tags that these are harm tags, and so as such, our processes surrounding transfers and discharge in each and every in our facilities is crucial to nail down, and it's crucial to analyze, reanalyze. Make it a part of QAPI to be sure that we are executing on what we're saying we're executing on when we're moving patients across the transitions of care spectrum. It also addresses situations where the discharge location did not meet their needs, which could lead to, if that was indeed the case, and we knew about it, we did not make every effort to try to mitigate that, it could lead to a discretionary denial of payment for new admissions, which we know for facilities, it's a very detrimental effect, to say the least, especially with the economics of nursing home operations nowadays. There's a new F tag that has been put under the transfers and discharge section, the inappropriate transfers and discharges, which addresses the requirements that a facility has to meet to transfer or discharge a resident, basically in an effort to protect the resident from an inappropriate transfer or discharge, i.e. compromising their safety. And so working towards making sure we have policies or workflows that allow residents to return to the facility following a hospitalization or therapeutic leave. Basically, dumping, and we see this from time to time. We see patients discharged to the hospital and facilities at times saying, "We don't want them back. We don't want them back." Well, we have to firm up why and what the rationale is and what needs we really can't meet for that patient. And what we did was, that got us thinking. Well, sure, the medical director does have a hand in that, because at the end of the day, the provision of clinical care services in a nursing home and the adequacy of those services does fall largely on the medical director. So, we are charging our directors to consider reviewing any facility policies or cadences that ensure that it includes steps to allow a patient to return after a hospital stay or therapeutic leave. Under this tag, we also need to ensure that we do not discharge or transfer residents in an unsafe manner to a place that cannot supply or support the resources the resident needs. So simply discharging without the appropriate home health care orders, without appropriate DME, without appropriate follow-up plans could put us into the crosshairs of FTAG 627. And so from a directorship standpoint, we want to be sure we're engaged with you all on any policies, procedures, or cadences you have. And when we discharge or transfer patients to lower levels of care or let alone higher levels of care, just make sure those transitions have steps associated where we can definitely prove that wherever we are transferring them, that the resources that the patient's needs will be there, or at the very least, that we've attempted to secure all the resources that they need prior to that transfer. There's a lot in this one. Once again, evidence, including documentation in the record that supports a discharge or transfer no matter the reason for that discharge or transfer. So when we talk about the clinical team on the ground, the director, the attending, the advanced practice provider, documenting if the patient's needs will be met at the next lower level of care. So what medical needs would the patient have? Does it require home health, social services in the community, adult protective services, medical team follow-up appointments, and making sure that our clinical teams are documenting that so you all can capture that, harness that, and make the appropriate plans as well, and make sure all the check boxes are fulfilled when we transfer them to a lower level of care. And finally, if they're being discharged because the facility cannot meet the needs, we have to have documentation. And for the longest time, the documentation burden, a lot of it was falling on the facility, but this is now looping in more firmly the attending physician and the provider teams to specify the needs that cannot be met. So once again, the collaboration between our clinical teams and you all, directors of nursing, administration, maybe even MDS, is crucial to understand what needs can we not meet for this patient, and let's all get it down in documentation. What efforts have we made to meet those needs? Have we called external vendors, contractors, or whatnot to plug in that gap? And if so, fine. If not, that is part of the checklist that we need to consider. And then, of course, we have to identify that if we are transferring them, say, to another facility, can that facility meet their needs if we cannot? And have we vetted that? So once again, there's some key elements of documentation that we will need your help for and your partnership for, but all in the interest of maintaining compliance with this latest update and survey regulation. From a medical director standpoint, we want to be sure that there's either a policy or some form of cadence on what steps are to be taken when we cannot meet the needs of a specific resident, considering all of the points that I mentioned above. And then, of course, making sure that the attendings and APPs are documenting as such. Now, if you notice, I put a couple of different words here, whether we talk policy, whether we talk a cadence, whether we talk a workflow. I say that because, what my experience has been, and I would love to hear from you all at some point here, is creating policies and procedures puts things in writings, and you're held accountable to that, which is great on all levels because it creates firm expectations. But it can also be a double-edged sword where if you have one lapse in a written policy, that can come back to bite you. So I mention policies, I mention procedures, I say cadences because at times we may also have just kind of unspoken rules of engagement, if you will. My personal preference is policies and procedures in writing to serve as checkboxes, but I also know that could be a contentious point come survey time. So once again, I think this is a matter of preference by the facilities, your respective owner-operators, and leadership, and having your medical director work within that construct. A new FTAG 628 regarding the transfer and discharge process. Once again, the intent is to ensure the facility follows all the processes for transferring or discharging a resident, including the thorough documentation and information communication relayed to the receiving provider. And from a medical director standpoint, bottom line, I'm a big believer in asking questions at QAPI, asking very simple questions that are relatively open-ended, and quite honestly, just simply asking if all discharges and transfers have met the criteria. Gets people thinking around the table, gets people thinking about any exceptions that we may have encountered, documentation deficiencies, et cetera, and then allows us to root cause if necessary. So we are encouraging our directors to make sure at the QAPI table that we're bringing that question to the table to get people thinking about it. There is a little bit more guidance surrounding the use of against medical advice directive. Now, this is where it's important, and the wording is important. Now, and of course, based on the surveyor, they may or may not totally hone in on the wording. But what I will say is this. The verbiage seems to implicate that an AMA directive only applies when a resident expresses their wishes to be discharged earlier than outlined in the care plan. So that is not to say you need an exact discharge date. A target range is always satisfactory. A more specific date is always the best, but we know that that can also be a moving target in and of itself. But even if that changes, a care plan update can be made. So in our care plans for patients, especially on the short stay side, let's also be sure that we have a firm discharge date in mind and that it's in their care plan. Because if we want to, if we have a patient that's getting a little antsy, may want to go home prior to when they are ready, and we don't have a date in the care plan for them, technically, they can't leave the classic AMA style. Well, you didn't document a date in the care plan, so technically it was free range when the patient wanted to leave, so it's still on you to make sure it's a safe discharge for the next step. So it's just a bit of a language play there, but it's something to keep in mind as we firm up our processes at the facilities. All right. Now, I know the thought on everyone's mind is big issues surrounding psychotropics, and we're going to get to that because I saved the best for last. So just hang tight for me. We're going to get through on this, but I wanted to touch on some of the other ones first. First, QAPI improvement activities, FTAG 867. The hallmark there is guidance that seeks to add or incorporate health equity concerns into QAPI activities, specifically surrounding certain factors such as race, sexual orientation, socioeconomic status, and preferred languages. And basically, we'll now, when we analyze data at a facility, we'll not only have to analyze data as a whole, as a facility as a whole, but we'll have to break it down by subpopulations, such as those of certain race, certain sexual orientations, certain socioeconomic backgrounds, preferred languages. We'll have to better understand these dynamics in our patients, identify them, know that they're in our building, and when we report any concerns surrounding clinical outcomes, that part of our root cause is breaking it down by certain populations and demographics. So just something to be wary of going forward. It will put a little bit more pressure on whoever's collecting the data at the facility level or even at our level, but nonetheless, it's required. And quite honestly, it seems to be a move in the right direction, given the heterogeneity of people that we typically see in our facilities. So our action step here is really just to say, look, let's take a pause, have a discrete discussion at QAPI on if there are any trending care concerns specific to any of the subpopulations mentioned. Do we see some issues surrounding infection control for African Americans as opposed to Caucasian and vice versa, for instance? Are we seeing any delay in care or nursing care concerns with those of certain sexual orientation of A versus B, for instance? So we want to be able to break down that data that granular. We also want to take a look at it in the context of the clinical care that they're receiving. Are we having a preponderance of complaints, let's say, about time spent or whatnot with a certain patient subpopulation in the facility? We want to be aware of that and correct that really quick. So let's just bring that to the QAPI table and know that this is an ongoing thing that we just need to keep track of. All right, pain management, FTAG 697. Not much has changed with the exception of defining what constitutes different types of pain, whether we're talking acute, subacute, or chronic, and a mind shift towards consider prescription of immediate release opioids instead of extended release or long-acting opioids. There's been, we know we have an opiate crisis in this country, and a lot of this firmer language was born around knowing that fact, but also around the complexities of monitoring, say, people on extended release and long-acting opiates, the risk of adverse reactions and whatnot, which is high with both categories, but we could definitely see a subset of adverse events with extended release narcotics that we may not see with short acting. So the language has loosened up a little bit to say if you need to use immediate release and you find it in the best interest, and even though a long acting might be the thing to use per evidence-based guidelines, you're not going to get jeopardized or penalized if you decide to use an immediate release opiate for specific reasons. The goal is documenting why you chose one type over another. Facilities are encouraged to conduct assessments and create care plans for patients on prescribed opioids, so need to make sure those are in place. It emphasizes the rights of the residents to be informed about risks and benefits of treatment. And so from a director standpoint in action, quite honestly, it's simplistic in its statement, probably a little bit more challenging on the execution, but with the likes of Jamie Smith, I'm sure that we can fill that gap pretty readily. But really ensuring facility staff, in addition to medical staff, are in service and able to speak to risks and benefits of opiate therapy. It's not, our NPs, PAs, and docs may not be at the bedside all the time, yet if we're giving orders after hours, weekends, and whatnot, and they need to be started, it would be amazing for nursing staff to be able to speak to risk benefit as well, so you can capture that in your documentation as well to help maintain compliance with this guidance statement. And with that, everyone's familiar with critical element pathways. These are question banks basically surveyors come in with certain things, whether it's hospitalization, whether we talk pain, whether we talk psychotropics, unnecessary meds, et cetera. And it's kind of a script on questions to ask. And if you notice in red, these are the new questions that have been added as part of this guidance statement. And as you can see up here, everyone in the facility, all key members of the clinical team are going to be involved in that questioning. And keep in mind, one of the biggest things with this survey update is the ability, or the requirement, that all stakeholders across the board are questioned more on certain decisions. That could be highly variable depending on the surveyor that's coming into your building, of course, but we want to be ready. And so part of this, putting this out there, is just to make sure that we're ready and that we know what they're going to ask. If it's preemptively no, we can wrap our minds around it, and definitely not fumble when the time comes to reply to the surveyors when they come a calling. FTAG 880, infection control, is pretty straightforward. In an attempt to reduce the spread of multi-drug resistant organisms, we've been employing enhanced barrier precautions for some time since the guidance first came out, but just more of an emphasis on this guidance statement for this latest update. And so from a director standpoint, once again, simply asking the question at the QAPI table: are all appropriate patients that would be potentially at risk of MDRO infections and communicable diseases, do they have the enhanced barrier precautions placed? Whether or not these enhanced barrier precautions do what they're supposed to do, and of course, contaminant with that, the significant efficiencies that we lose as a result of this, the regulations here, it's necessary in the attempt to help reduce high-risk infection rates in our facilities. So let's always ask ourselves that question, making sure that it's a discrete point at QAPI that's discussed. All right, we're going to be easing in, segueing into the meat of what I get a lot of questions about from facilities. Is let's start moving into the granddaddy psychotropic updates, but starting with FTAG 658 professional standards. They did put the medical director front and center in that FTAG 658, and there'll be a much more diligent, a much more laser-focused eye on how diagnoses are made, how are they documented to satisfy acceptable standards of care and criteria. And of course, with the specter of psychiatric diagnoses around us, there'll be specific attention given to anything that codes back to schizophrenia. So whether we're talking schizophreniform disorder, schizoaffective disorder, when MDS captures those, it all comes back to coding as a schizophrenia diagnosis. And if they are on antipsychotics, and if the diagnosis of schizophrenia, schizophreniform, schizoaffective, whatnot, has not met the acceptable standards of diagnosis, DSM, there's going to be questions. And so we want to be sure that with our facility partners, we have processes in place to scrub medical records and documentation to be sure we have it. From the practitioner standpoint, please believe me when I say all members of the mental health team, the primary care team, have been in service on the need for diagnostic stewardship. I like that because it means stay attuned to how you're diagnosing something and how you're documenting something. So from a medical director standpoint, quite honestly, just reinforcing the standards of care for the most common diagnoses. I mean, this could be something even trickled down like diabetes. If we say someone is diabetic without at least one A1C or a serial finger stick reading or a fasting glucose or, well, we know we don't do it, but a 2-hour glucose tolerance test, which we don't do in this setting, the diagnosis technically is not established in the eyes of the surveyor. So we just want to be sure that for every major diagnosis we come across with a specific emphasis on psychiatric diagnoses with specificity under that of schizophrenia, that they meet the standard of care in terms of arriving at the diagnosis. And at QAPI, once again, simple question: are there any concerns related to the diagnoses to the various diagnoses that each of our patients have? Are we missing documentation on anyone? Simply raising that question raises awareness and allows people to think through to see if there's a true problem or not. This is an example of an FTAG 658 noncompliance where we admitted someone, or there was an admission, someone was admitted with a diagnosis of schizophrenia and antipsychotics were given for behaviors. There was no known prior history of schizophrenia. The medical record didn't contain an evaluation to support the diagnosis by the practitioner. The symptoms for which the antipsychotic was prescribed, aggression, agitation, etc., did not align with typical schizophrenia symptoms. Given the failed documentation and the failure, quite honestly, of any gradual dose reduction attempt, there was a noncompliance on the tag. So just so we know, documentation as to the rationale of arriving at a diagnosis using schizophrenia as an example, but extrapolated across almost any medical problem will be paramount to look at. And your medical director needs to be intimately involved on any concerns you may have with regards to documentation for certain diagnoses. All right. FTAG 841, responsibilities of the facility's medical director. Basically, clarification, bold-facing, put it in our face of intervening, implementing, and overseeing. Just those 3 words: intervening, implementing, and overseeing. Intervening when care is inconsistent with standards of care and offering remedies to that. Helping to implement resident care policies, and especially if we have policies surrounding the prescribing of antipsychotics in a building, and overseeing the implementation of resident care policies, i.e. measuring those policies to certain outcomes that we're expecting in the facility, perhaps something to bring to the QAPI table. They also are reinforcing the fact that the facility's medical director now should be actively involved in the process of conducting the facility-wide assessment, and surveyors will be required to interview the medical director, as we alluded to earlier. And this is all FTAG 841 puts into highlight, well, what the heck are the medical directors going to be asked? We're going to dive into that a little bit later with the critical element pathway. You saw the one for pain. We have another one for unnecessary medication and chemical restraints. But bottom line, this FTAG reemphasizes that your medical directors need to be ready for questioning on a more concerted basis by the survey team. So for F841, what are some things that we can consider from a medical director standpoint? Well, once again, can we review any facility policy or cadence on diagnosing and prescribing medications and intervening with a provider if necessary if they're not following certain standards of care? Anyone on the care team, physician, nurse practitioner, PA, nurse, nursing leadership, DON, even MDS, if you ever have any concerns that I have no idea how they came up with this diagnosis, that needs to be brought to the medical director's attention. The medical director then needs to do a chart review to find out what's what, and then have a direct conversation with the providers to be sure that they're employing the proper criteria to arrive at the diagnosis that they have. As far as facility-wide assessment, we know what it's for. You all know what it's for. It's to determine what resources are needed to care for each and every resident under that roof. Each and every resident. Some of them may have very specific needs. So the bottom line question is, do we have everything we need to take care of those long-term care patients, those with any specific needs that are out of the ordinary? And the answer to that has to be yes. And if not, we have to procure it. So we have to look at staff competencies. Do we have a lot of TPN? Do we have a lot of trachs? Do we have a lot of this and that go out of the norm, let's say? If so, are the staff proficient and competent enough, have competency to be checked off on? If not, we got to fill that void. Are there any additional in-house services needed? Respiratory therapy, if we have a lot of patients on Trilogy, or once again, having trachs in the building. chronic ventilator patients and whatnot? Do we have specific types of diseases or conditions in the facility, rare diseases, for instance? If so, do we have everything that that patient needs to help care for them? If so, great. If not, we need to procure it. And then, of course, always making sure that any vendors coming in, lab, radiology, wound care, pharmacy, dentistry, you name it, the medical director should have some general sense as to obviously who they are and how they're performing, and making sure that they are able to meet the needs of every resident as those needs arise. So in the past, the assessment was done by the facility. Medical director sometimes just signed off on it, and there we go. Well, this is going to be a lot more concerted effort to bring them in and to do an analysis on the population to see if we're truly meeting the needs of those that are residing under that roof. Medical director actions to consider, once again, we go back to mental health diagnoses. Are they being made relative to established criteria? And that QAPI, once again, bullet points. Was any of the above a concern in the prior, or is it currently a concern in the current month? Once again, ask a simple question. Be surprised at how many wheels that gets turning and how much is born out of those simple questions. All right. And this goes into some tag examples for a medical director responsibilities. And I will say there's a common theme here, and that is did not intervene, failure to intervene. And I'm going to go back again a couple slides. Intervening is the first part of this. So the minute something feels like it's falling off the rails, the medical director must intervene to avoid these sort of scenarios, high-level tags. Intervention and a plan will mitigate, regardless of the outcome, many times, a high-level deficiency, as long as they're seeing that it was found, intervened upon, followed through with the PIP. All right, here we go. FTAG 758 to 605 transition, basically taking unnecessary psychotropic medications and placing that under resident rights subsection chemical restraints, which changes the whole dynamic as to how we think about psychotropic medication. And there's a lot to this tag, so bear with me. We're going to try to get through it as efficiently as possible. So number one, FTAG 758 was the unnecessary psychotropic medication tag. 605 is the right to be free from chemical restraints. So all they're saying is everything from here is going to be put under here, and this is a resident rights issue now, which is a big level harm if we are not able to comply. But just know that FTAG 757 will stay, which are just unnecessary medications, ex psychotropics now. All right. So what we're going to do in a bit is really define what is an unnecessary medication, specifically an unnecessary psychotropic medication, which will now be deemed a chemical restraint until proven otherwise, proven through documentation, diagnosis, etc. Medication should not be used for staff convenience or staff discipline. We're going to go into a couple of examples of what that is. Psychotropic medication should be a last resort after non-pharmacological interventions have been deemed unsuccessful or are contraindicated. And finally, as with any treatment in medicine, but specifically now at psychotropics, the resident has a right to be fully informed of and participate in or refuse treatment before it is initiated. And we'll go into details on these here in a bit. So I know Barb Pereira is on the call. Barb, do you mind chiming in on psychotropic medication, kind of the new nuances with it? If you don't mind introducing yourself and then just diving right in, please.
Sure, of course. Thank you. Hello, everyone, and thank you for having me. So I'm Barbara Pereira. I'm a pharmacist and very happy to be with Eventus, we're a really super forward-thinking company that does value puts a lot of faith into the value of a pharmacist. And I'm very happy for that. Happy to be here today to talk to you all about psychotropic meds and love the impact that we can have on your patients. So psych meds, this is actually not new. What the question as far as what is a psychotropic med? This is something that came out in 2016. They had some older definitions, 2016, which some of you are familiar with, what was called the mega rule at the time. CMS said, you know, we're on to you guys. We know you're using Depakote and other, maybe seizure meds, or you're using Benadryl to treat psych issues. So they started to include those, and they changed the definition, and they said, now we're telling you that a psychotropic drug is anything that affects brain activities. So in a nutshell, it's any drug that you're using to target a behavior or a psych issue. And verbatim from the regs, it says these include, but are not limited to, those 4 popular categories of antipsychotics, antidepressants, anxiolytics, and hypnotics. Then they added mood stabilizer. It is also, in addition to mood stabilizers, anything else that we're using. So we use Atarax quite a bit. Atarax is an antihistamine. It's for allergies, but we use it quite a bit for anxiety in our population. So that is because it's being used to target a behavior or a psych situation. It is being now considered a psychotropic med.
All right. Thank you
Thank
so
you.
much, Barb, for chiming in. Really appreciate it.
Of course.
And you know, I think there's no time like the present for everyone to ensure that your relationship with your consulting pharmacy team is airtight. This is going to be very important to not only identify gaps or lapses in care, but gaps and lapses in documentation, so the burden is not fully on you or just us. There's a third hand in all of that, but also then to help problem solve through when we find potential deficiencies. So I think the era of pharmacy consultancy has never been brighter here, because this is really going to bring their value to light. So what's a non-necessary medication? Bottom line, it could be one or any of these, okay? Any amalgamation of these criteria. A medication that's prescribed without a documented indication, so a firm diagnosis. A medication that's prescribed in excessive doses, i.e. above traditional doses. Why is someone on Lexapro 40 milligrams? For instance, that's not a traditional dose and may seem excessive. Or duplications in therapy. We see people sometimes on, for whatever reason, 2 antipsychotics, 2 SSRIs, 2 muscle relaxers. And I throw muscle relaxers out there because when we talk about psychotropics, anything with brain activity, some of them do have that effect. So that if you have a nitpicky surveyor, they could also hone in on those types of medications. Of course, the focus is going to be on psych meds, but just know they could always bring that issue up. Any medication that's prescribed for an excessive duration. So bottom line, GDRs are critical. You all know that. We know that. We just want to be sure the documentation reflects attempts and or contraindications to further GDR if and after the first round of the required GDR attempts. So if we're GDRing, if we are eventually deprescribing medication, we remove the burden of excessive duration, and at the same time, the patient benefits. Medication prescribed without adequate monitoring. So if your specific psychotropic medication requires specific labs, specific, let's say EKG for some of them, a QT interval, for instance, if there's no, or even just routine follow-up. If the general consensus, if someone is on medication X, should be followed up 4 weeks later, 8 weeks later, et cetera, that follow-up needs to be in place. So if we're missing any of that, this is where the pharmacist really can help us. We need to plug that gap. Or a medication continued in the presence of an adverse drug reaction or ineffectiveness. If it's not working, push back on the clinical team to say, can we just try it off? Or if they're already having an adverse event, which we could attribute to a specific medication, and they still get that medication, it's time for a rapid GDR and or deprescribing initiative. Barb, your hand is up, please.
It is. So thank you. I really just want to chime in here because I love to give examples of some of what these bullets are to make it kind of really hit home. Real life practical examples. One situation that I just recently came up with, one of my roles at Eventus is I do reviews on every patient that gets referred into our palliative arm of to our palliative team. And I came across a patient the other day that actually we were adding antipsychotics for hallucinations, which would be very appropriate because hallucinations can't really, if we've tried all non-pharm interventions and ruled out medical etiologies, sometimes these adverse drug reactions, I want everyone's ears to sort of perk up. Sometimes these drug reactions are very subtle or not as obvious. This patient was actually on 2 SSRIs intentionally. They were actually on Prozac 40 and Lexapro 20. And then we're adding olanzapine to treat hallucinations. So we have to get into this whole conversation of were those two SSRIs, like maybe too much serotonergic activity? Was that the reason that we found the need for us to be in a situation to add an antipsychotic? So that's really a recent real life example of something that I came across, and it was sort of overlooked. So look for those subtle symptoms. One rule of thumb that, as a pharmacist, I have the luxury of being laser focused on medications and what the impact is and what their effects are. Rule of thumb, any new symptom that your patients are experiencing, the very first thing or one of the first things you should always consider is that is a side effect of a medication, and that we're not getting into the prescribing cascade where now we're adding a med to treat the symptom or side effect that we caused from another med. So thank you for.
No, excellent points, Barb. Thank you for chiming in there. All right, just moving forward into the different dimensions of psychotropic medication and that specific FTAG. We talked about using medications for staff discipline and convenience. So when the staff member is using it for discipline, it's usually to correct an adverse action that the patient is exerting, punishing a resident or behavior. Some examples that are real life: wandering into other residents' room, and the medication is given to restrict going around and wandering. A resident resists receiving a bath. And instead of non-pharmacological interventions, we run straight for the drug just so we can shower them. When we talk about convenience, anything given by staff so they expend less effort to meet a resident's behavioral needs. So i.e. not wanting to take the time to implement non-pharmacological interventions. So residents have sleep issues. So to force them into a normal sleep schedule, we'll run for the pill as opposed to documenting or documenting non-pharmacological interventions first. They're given a medication to restrict to their chair because they keep falling, basically doping them up so they stay seated so they don't fall. That's staff convenience again. That's not utilizing non-pharmacological interventions or other methods to avoid the behavior in the first place. Now, don't get me wrong. There will be instances where if the patient is a significant harm to themselves or others, and if non-pharm does fail and it's been legitimately tried and documented, that is a role of medication. But what we're alluding to here is, and once again, I don't say this about everyone, but we do have facilities out there that unfortunately don't document non-pharm interventions, let alone have a plan for those in the first place. So I'm just re-emphasizing the point. We run to meds after non-med things have been tried. And if we do that and we document it and they fail, we're okay using some medication to promote patient safety. When we talk about the non-pharmacological interventions, the burden of this documentation per the language is on the facility. But I always believe in partnership. At the very beginning, the title slide, leadership through partnership. So we don't want this to be all a burden on you all. We want to help a little bit with that. We should be asking, as practitioners, clinicians, psychotherapists, psych med, walking into your building and asking staff if non-pharmacological interventions are being utilized and if they are doing their documentation. Then, of course, we will document in return saying, yes, they are. They tried X, Y, and Z. Medication's appropriate. It just further helps bolster not only collegiality and teamwork, gives people some more skin in the game, too, by directly asking frontline CNAs and nurses, are you guys doing this so we don't have to use the pill so much on Miss Betty? And it really gives them some empowerment to take charge and do things so that Miss Betty is not constantly medicated for things. We could also, as a clinical team, i.e. Eventus clinical team, we could also just reference the care plan. If there have been care plan for specific behaviors, and in those care plans, if non-pharm interventions have been employed or not, and if they've been documented as such, I would ask that facilities that do care plan behaviors, well, all of them do, and that have specific non-pharm interventions planned as part of the care plan, we now find a way to make these care plans evident to the clinical team, easy to access at the drop of a dime while they're documenting, because I can tell you right now, your documentation, though the burden is on you, the 1-2 punch of teams like ours also documenting it is powerful in the eyes of the survey. It shows cohesiveness, it shows collaboration and a commitment to excellence. So with that said, I just ask facilities, going forward, wherever these care plans are hidden and whenever these non-pharm interventions are, wherever these are being documented, that you please tell your clinical teams, your physicians, your medical directors, your APPs, where they can find them for ease of access so they can integrate them into the documentation rather efficiently throughout their workday. And from the director standpoint, once again, at every QAPI, simply asking the question if non-pharm interventions are routinely being documented and success and failure in tandem being documented with those. Simple question, gets people thinking, yes or no. If no, we start analysis, root cause analysis, and dig in. The resident right to be informed. Now, this is the particular sticking point, I think, for a lot of people on this call, and I think everyone in general. The language is very vague. Well, who really does it? Now, the burden of responsibility of documenting is kind of shared with this statute. The bottom line, something needs to be documented, that if we're going to start or increase the dose of a psychotropic medication, there has to be a discussion with the patient or the responsible party, if the patient can't answer for themselves, on the drug being used, what are they using it for, risks and benefits, including things like if there are any black box warning on some of these medications, and then whether non-pharm interventions have failed or are contraindicated, necessitating the use of medication. So once again, consultant pharmacists, our practitioners in your facilities, and the facility team themselves, all working in tandem to make sure this information is ready, accessible, so that we can then help you with the documentation of the rest of the requirements, such as conversations to be had by patient or the responsible party. We do emphasize from our standpoint that, part of being a great clinician is, well, just speak with the patient at the time of your visit and just go over some of these things. It really doesn't take that long, and then document them. Primary care teams working in tandem with our behavioral health teams to ensure these discussions are had, and that we're finding and that we are going through the various dimensions of conversation that we need to have to start these medications. And, as you all may or may not know, we have an entire care coordination team which can help further support teams to initiate these contact points for patients and families. It's not for every patient, but our practitioners have that ability. But of course, in tandem with that, facilities. I've heard from facilities that some of them just want to take the full control of the initiating call. And if there's questions, concerns, etc., bring them back to the provider. I know this is highly specific based on what your corporate ownership may want, but this is a time for discussion with your teams on the ground, your medical director, to create that cadence and flow so that we can go forward and document what we need to document to get the patient at the care that they need on a timely basis. Noting also that if there's a lag in conversation of any sort on either end, we also don't want to start getting to delay of care and whatnot. So let's all make sure that we have processes in place as to who owns what, so that everyone knows kind of their role as it relates to starting or increasing a psychotropic medication. Now, what I'm about to dive into next, I'm not going to read verbatim because it's available to you all through the CMS Operations Manual, that nice 900-page document that I know everyone knows by heart. But I will say this. Red in the Operations Manual means new. And so when we look at critical element pathway for unnecessary meds, chemical restraints, psychotropic medications, and MRR, pretty much everything in the critical element pathway is red. They've reinvented the whole thing. And what I want specific focus given to, especially now we're focusing on FTAG 605, not to say 757 unnecessary meds is not important, but the purpose of this discussion, FTAG 605. So note, surveyors are going to be in your building focusing on these checkboxes here, observing for those, checking for sedation, sleep issues, checking to see if non-pharm approaches are indeed being utilized in real time. All right, let's go a step further. Next page, we have F605, asking residents, family, or their RPs, interviewing them with specific question sets to assess for compliance or non-compliance. Your nurses, CNAs, DONs, social services, as Jamie mentioned earlier, every member of your team needs to know what's coming down the pike, and actually they need an in-service on everything that they could be asked. So we just need to work in tandem with that to make sure they have the resources and, quite honestly, the in-servicing necessary so they're all up to speed. But they're not missing anyone in the home here. As you can see, they're going through everyone to question on FTAG 605 and 757 for that matter. An attending physician, once again, a series of questions, asking if GDRs were performed. Are they aware of GDRs? All the more reason why at the QAPI level, if there's deficiencies in your GDR documentation, it's not only just your mental health team going forward. Please relay that to the primary care team so they can work in tandem to shore these pieces up for the facility. And of course, making sure that the patient, once again, is getting the care that they need through GDR and deprescribing a medication when appropriate. And we talk about medical director here at F757-605 with regards to chemical restraints and adherence to standard practices. We talked about standards of care under professional responsibilities. Well, it's also lodged under here on these tags, F605 and F757. Do we follow a standard of care when utilizing certain medications, for instance? So we have in-serviced our team members on this, of course, through patience and practice. This is going to be something that we'll keep re-ingraining in them. I would advise on the facility side too, this is going to be a continuous rehash. Set a cadence by which you're constantly bringing these critical element pathway questions up and training your teams on them. Because it's easy to forget in our day-to-day, the crazy amount of work that we're all doing. And so I would advocate a couple times a month that we're constantly bringing this fresh and new. I would like, Barb to also chime in on the role of the consultant pharmacist, because as you see, there's 6 new questions the pharmacists are going to be asked about this. So Barb, can you please chime in a little bit here?
Yeah, sure thing. So, when I took a look at this and the 4 slides here, right, this is the 4th one. There's 2 points I'd like to make here. The first one isn't actually answering your question, so I apologize. But the first point and the key takeaway for me was they're serious about this. They're really involving, like Jamie said, and Dr. Patel emphasized, everyone in that building. Look who they're going to interview, from the CNA to the family to the patient, all the way up to the medical director. They're serious about this, and look at the questions they're asking. They're very extensive. So that's 1. But 2, to your question and to make the point, I really feel like what this is telling me with these questions on here now regarding your consultant pharmacy, your relationship with your consultant pharmacist matters more now than ever. And it is super important that you at least maintain some certain level of engagement, and you need to engage them. You really want to make sure that they are familiar with these new regulations, which I will give them the benefit of the doubt. Most of them are. That they're familiar with these, they're engaged, and that they're held accountable to actually know the answers to these questions just in case they get asked. So make sure they are familiarized with this, and make sure they're prepared and they know how to interact with surveyors. That was one thing that I did. So I've been in the post-acute space for about 25 years. 20 of them were sort of in the world of consulting pharmacy. So I worked as a consultant and then managed consultants. The last 5 years, I've been very lucky to have pivoted over into a role where I am in a physician's practice, which is actually really ideal for me to work directly with physicians. The impact is just tremendous. So it is possible to have a really good, engaged, positive, healthy relationship with your consultant pharmacist. Make sure that they are willing to partner with you to the extent that these new focused there are not new regulations, but new focuses. Make sure they're ready to partner with you. If you're having any gaps, please reach out to your providers at Eventus and let us know. We actually have an arm that we're starting some consulting pharmacy. And in my opinion, and maybe it's just a little self-focused, it really is the ideal situation because we are directly engaged with our providers who are writing all these orders and ordering these meds. So you deserve, and your patients deserve, to have a highly engaged consultant pharmacist. If there's any gaps in that, either push them for it or reach out to someone at Eventus.
Thank you, Barb.
Of course.
They're also going to be looking at those changes in behaviors as part of the question sets along the critical element pathway, but I wanted to break these out in particular. Note that until we demonstrate otherwise, surveyors will go after symptoms like this and attributing it to a psych med until we prove them otherwise. And how do we do that? We see a lot of patients eating less for many reasons. We see a lot of patients more sedated than usual for many reasons. They lose weight for many reasons. They lose interest, yes, for depression or withdrawal withdrawal from activities and whatnot, but it could be also them not feeling well for many other reasons. So I say that because anytime we observe patients with symptom changes, change in condition, evaluating that through a broad differential diagnosis actually has never been more critical. It's always been great medicine to do, but showing and demonstrating that, you know what, patient is a little bit more sedated. Let's not give the survey team ammunition to say, well, there was nothing else in the record that said you were looking elsewhere, so it must be the psych med, right? Let's show them that, no, nursing did a complete assessment, complete vital signs from finger stick blood sugars to heart rate, blood pressure, pulse ox, their baseline sensorium, what they've eaten, drank, and the trend of that over the last 48 hours. And then let the primary care team work a broad differential. Let's get labs done. Let's start some fluids, or if that's appropriate, let's look at other medications, i.e. blood pressure pills, diabetic pills, other things that can compound polypharmacy effect. And the more we could document that approach, the more then it shows the surveyors that it may not necessarily be the psych med. But it's also just the right thing to do for patients as it relates to clinical care. So I just say that because it's not just clinicians having to work through this. Great nursing assessment and S-barring, changes in condition, are crucial to ensure that the finger pointing doesn't go to any one medication, because we know these patients, things happen for so many reasons beyond just their psych meds. So let's keep that in mind, and let's make sure that we're all working together to create the broad differential diagnosis and work the problem as it presents itself. All right. And we know that if we start combining all of these deficiencies, we can have one single issue, the inappropriate use of a psychotropic medication, tagged back or compounded back to 3 tags at once for one instance. Whether you're talking 605, whether you're talking 641 on the MDS side, whether you're talking 658 from the professional standards and diagnosis side, one infraction can lead to 3 tags. So all the more reason, once again, we got to have our ducks lined up in a row. We need to be working together as a team, identifying deficiencies at the QAPI table, and proactively addressing those deficiencies over and over again. I want to just run through some examples here for FTAG 605. This is an example of a severity level that presents to the level of an IJ. Failure to recognize the use of an antipsychotic medication originally prescribed for agitation has caused significant changes in quality of life. They no longer participate in activities. They have difficulty concentrating, carrying conversations, isolated in their room, and sleeping most of the time. And there was no adequate clinical indication, i.e. no firm diagnosis or appropriate diagnosis made and documented. GDR attempts were not seen. Non-pharm interventions were not documented or plus or minus not attempted. Either way, if it wasn't attempted and it wasn't if it wasn't documented, it wasn't done, even if you did it. So get the documentation down. Resulted in psychosocial harm. This is an IJ level tag. I mean, not so serious, but still a harm level, level 3. Resident has a PRN order for psychotropic to treat anxiety, but staff regularly give the PRN with no documentation, no documented indication as to why. During interviews, staff explains it helps the patient sleep, so they give it nightly, even despite the patient not requesting it. Resident's been sleeping through breakfast, now has weight loss as a result. Oops, sorry. This represents what we alluded to earlier, staff convenience. All right, so, and it also alludes to the fact that why, and whoever your mental health providers may be at your facility, when we talk about PRN specifically, got to abide by the rules. We've got to abide by the 14-day rule. Every 14 days, even if it's justified to extend the duration, it's got to be almost like a stop and watch. Come to the 14 days, observe if the medication's still needed or not, and just get it off the cart. If not, don't give staff members or whatnot any way to give something for an indication that's not appropriate and lead down this track here. It doesn't do right by patients, most importantly, but secondary, we're going to be out of compliance. All right. So with that, let's go to the bottom line here. Number 1, it's collaborative. We talked through the multiple stakeholders involved, the most important stakeholder in all of this, the patient. Number 2, this is not necessarily new regulation. It's a new emphasis of regulation. Elements of critical element pathways are new. So we'll learn together, we'll evolve together, and we'll improve together. So will mistakes be made? Yes. The question there is not if any one member of that team is responsible for that mistake, but damn, mistake was made. let's get together at a roundtable, let's patch it up, but beyond the patch, let's create a series of action steps that results in this not happening again. Because as I said, this is going to be a new flow for everyone to some degree. By doing so, checking the regulatory checkbox is great. The compliance checkbox is great. But also, I truly do feel that despite some of the burden this might initially place on facilities and us as provider teams, I do think it's in the interest of improving quality of care. So if we take it in that vein, a purpose of promoting better care, maybe a little bit of an easier pill to swallow. And finally, remaining unified, we foster a culture. We need a positive work culture in these sort of environments now more than ever. We need continuous improvement, that culture that drives continuous improvement, teamwork, and accountability, and therefore trickles down to the patient providing excellent care and outcomes. Jamie, Barbara, any parting shots here?
Sorry, I had to find my little mute button. No, Dr. Patel, you did a fantastic job of really covering every aspect. These slides are very, very thorough and comprehensive. My parting words are really, we don't really know where this is going to go until it actually goes. And we will, like every other change in interpretive guidelines that has come out in the 25 years I've been doing this, they will, I would almost guarantee you that they will review all of these things during their upcoming surveys as soon as this starts. They will be looking at discharges and transfers and pain management. And like every other survey, meds are always a really big focus. They're going to be digging through your schizophrenia diagnoses and making sure those are validated. I don't promise they're going to do that in 100%, but they will 100% do that somewhere. So it's going to vary what state you're in and how those particular surveyors have been trained and what team of surveys you get, but they will be looking at that. So, moving forward, I'm hoping that they use it's common sense and that they go easy on us all. And that, the outcomes for our patients remain unchanged or get better, I should say, that there's no negative outcomes for our patients, that I'd hate to see meds withheld because we're afraid to use them. So I'm all about the outcome. So, and I really do appreciate you listening to my little tidbits of wisdom today. Thank you.
You both did an awesome job. And for those of us on here, you'll see in the chat where I posted a PDF. I posted here a newsletter on this topic where we top line some of the main points that Dr. Patel went over. Please share it with everyone, your frontline care force. Everyone needs to be aware of these changes, your CNAs, your nurses. We want to keep everyone in the loop. And you can open up the newsletter and read it. And don't forget to click the link there and win a potential chance for some Starbucks coffee.
Thank you, Barb and Jamie. And to close this out, look, I know challenges are ahead of us, but if we frame the challenge as an opportunity to reinvigorate a culture of teamwork, working together towards a common goal of maintaining compliance with the end goal of improving care, it becomes a wonderful opportunity to show what an integrated care model partnering with committed facilities looks like. Quite honestly, we have an opportunity to make a huge dent on a larger stage together. And I wholeheartedly welcome everyone on this call to continue that mission together. So with that, I will go ahead and if you all don't have any questions to insert into the chat, I'm sure we will be available to you for any further questions that you may have at some other time. All right. Thank you all and have a fantastic weekend.
Thank you, everyone.
Thank you.